It is now 11 o'clock, so we will go ahead and get started. Thank you all for joining the Georgia Department of Public Health Strike and Support Team Office Hour. I am Maya Labat, your host for today's event. Please keep in mind that this event will be recorded, and I will hand it off to Melody Brown from Alliant.
Thank you, Maya, and thanks again, everyone, for joining us today. We have a jam-packed hour for you all with Dr. Swati Gar and Department of Public Health. So, Maya, if we could have the next slide, please. Again, we have Dr. Swati Gar this morning, Regina Howard, and Teresa Fox that will be presenting. Unfortunately, Ravens Phelps is not able to be with us, but we do want to thank her and Renee Miller for their input on the slides that we have for you all today. Next slide, please. We want to thank the Georgia Department of Public Health and the University of Georgia, our partners in this work, for the strike team. Without them, we could not be bringing you these presentations and these office hours once a month. So big thanks goes out to them every month. Purpose of these slides is to bring you updates on things that are going on with infection prevention, clinical protocols. Today we have a robust topic to discuss with you and give you some information on. And we ask that you ask questions. If you have along the way, Dr. Gar is probably going to have to leave us today, but we want you to still put your questions in chat, and we will make sure that we get those to her to get the answers back out. We have the office hours for August lined up to follow this. Today we're going to be talking about C. diff. So next month we're going to be bringing a presentation for cleaning and disinfection of shared medical equipment. And at this time, I'd like to put a shout out to each one of you. I see that we have some corporate contacts as well as independent nursing homes on the line today. Because we're going to be talking about cleaning and disinfecting of medical equipment, think about who would be the best to bring with you to this meeting next month. So maybe environmental services and laundry and other areas that may not be attending these, but please bring them. And also send the email invite that you get out to your colleagues and ask them to join so that everybody has an opportunity to get the updates that we're bringing every week. We're now in preparation as well. For October, we're going to do 2 large trainings, just as we did in May. So stay tuned. We'll be getting dates and information out about those trainings very soon to you all. Again, your opinion matters. At any time during this presentation today, please start dropping your thoughts and everything into chat that you want to discuss, or if you have questions. And also, we always want to hear about your best practices. So as Teresa, Regina, Dr. Gar go through the different types of information that they're going to share with you today, if you have a best practice that you've already put into place, please let us know about that, as well as your questions. So Dr. Gar, I'm going to turn this over to you, and I kind of put this in for hot off the press, COVID cases and COVID in general. Where are we now? So Dr. Gar, the floor is yours.
Thank you so much, Melody. And yes, that is hot off the press. What is going on in COVID? So I do want to share that, we do have to give our slides in preparation to make sure that they are all good a few days early. And since I sent these slides, data has come in, has been updated. And what we see now is a higher spike. So let me talk through this slide. I think it is important for us to remember what we are looking at when we look at the CDC data tracker. This is out of the CDC data tracker. And what we are actually looking at is those blue, that blue figures with the red line. And the red line is essentially the daily trends in the number of cases that 7-day moving average of cases. And as you can see, it kind of clearly reflects the number of cases that were happening. Now, what is happening today is that a lot of our community has those free tests or tests that they can buy over the counter, and people are not really reporting those tests. They are not required to report it. So if I'm a teacher and I'm at home on vacation, it's my summer break. And if I feel like I have a sore throat or a runny nose, I test, I test myself, I test positive, I quarantine. I'm not required to report. But what that does to the numbers is it underestimates them. So we think about what all could we look at, as a proxy indicator for what may be going on in your community. So remember when we used to like that time that we used to freak out when were over 5%, we had to wear face shields and all that stuff. So this is just an example of that. So what I did is the daily trends and number of cases in the people who were hitting the ED. So every time a patient is in the ED, they get tested for COVID for whatever reason. And then we look at what is going on. And what you can see is just what I said, that your number of cases are actually higher than what is being estimated by this red line. Since the last time, the number of cases have actually gone up, and the percentage of percent positivity, the one that I was talking about, that we used to really focus on for CMS guidance, has also gone up. So in United States right now, our percentage positivity of everybody who's hitting the ED is about 20%. That is pretty high. If that was happening in our community, we were like waiting for it to come into a nursing home at any moment, and it would have come into a nursing home, which is what we are seeing right now. The next slide is again something that will show you the current state of COVID. And these are the hospitalizations that are going up because of COVID. And what we are seeing is the same. The COVID hospitalizations have gone up to right now, they're about 6.5 thousand. So that is a pretty big number. So that number, from last week, which it was showing 5K, has actually gone up to 6.5. And that is a bit worrisome as well, because now the hospitalizations have gone up. All right, next slide, please. Yes, can we go back one slide? Perfect. Next slide, please. So the same situation is happening in our nursing home residents. More nursing homes are seeing COVID cases, and nursing homes are seeing increase in the number of COVID cases that they are having. Next slide, please. And this is what is happening with the staff. So how does COVID come into our buildings? I always say COVID doesn't live in our building. It comes inside from the community. So the staff is living in the community. Community has high rates of prevalence. Staff is testing positive because their family member or some friend or whoever is testing positive in the community, and then the staff brings it in. And this is going to be an important thing that we think about when we think about mitigating factors. Next slide, please. All right, see, the other thing that we do is wastewater surveillance data. Again, that is a good data because it really measures the activity of COVID in the COH. And that cannot be changed with whether testing is available or not. So what we don't want to see a lot of is what we are seeing a lot of here, the oranges and the reds and the yellows. So next slide, please. So this is again from only late last week. And what we saw is, look at the number, which says 15 in last 15 days, what happened to your sites. We saw is about 197 sites have 100% or more increase in the change. And now, when I looked at the data this morning, that has gone up to above 250. The largest proportion of sites that are the sites that have actually gone up in numbers. What is it telling us? Lots and lots of COVID activity around in our community. Next slide, please. All right, so what is happening and why is it happening? This may give a little bit of a clue. Again, this was before the numbers came out for this week. And what you can see is the BA.5 variant, which is the dominant variant. And last week we were freaking out because BA.5 had become over 50%. As of today, it is 65+%. So that's a huge jump that it has only, within the week it has done. And there are implications for that. Whereas BA4 continues to be somewhat stable at 15%, and the BA2 variant is being kind of pushed out of the community by the increase in transmissibility of the BA5 variant. So let's talk about the BA5 variant. Next slide, please. So what are the implications of BA5 variant? What do we know? A few things that you need to know just from an infection control perspective and managing your staff and patient perspective. One, it is something that is evading natural immunity. So people who had been banking on, I have natural immunity from previous COVID, it is called the escape artist. You are no longer protected by your own natural immunity that you gathered by having COVID before. So this is a very, very clear variant that is kind of saying, I am not like the last variant you had. You don't have any immunity against me. So this is a good time for staff who has not taken the vaccine, banking on that natural immunity, to reconsider taking that vaccine. And vaccines typically do provide that immunity that is a more standard immunity that we are seeing, and that is important. The other thing with BA5 variant, extremely transmissible. So it is like measles. If you're in the same room with somebody with unprotected exposure, you are going to get it. So that is another important implication that you have. Talk to your staff about, just for the time that this is surging in our community, it's a very good idea to avoid non-essential get-togethers. Wear a mask if if you're going in places that are indoor spaces with, people who are not wearing a mask, etc. It's very important to protect yourself while you're out in the community. The third thing is that you are going to have symptoms that are primarily what we are seeing is runny nose, sore throat. At this time, if my staff is saying, I think I have a strep throat, that gives you a direct license to test. Go ahead and test that staff member because they may not have a strep throat. They may actually have COVID. A lot of staff members who kind of feel that they have a strep throat are testing positive for COVID. So think about those symptoms primarily as well. Your 3 pillars continue to stay the 3 pillars. We are going to talk about vaccination. Vaccination is our number 1, 2, and 3 strategy, and I will tell you where it fits in. The other thing is PPE and infection control. We talked about staff keeping themselves safe, and how they can do it is vaccination is not going to be 100%. There has been no vaccine that has in our history of humankind that has been 100% effective, like there has been no medication that has been 100% effective. So what we want to tell our staff is 7 out of times you are going to be safe. You're going to be you have that chance of not catching COVID that is symptomatic if you are up to date vaccinated, but for that 3 out of 10 chance, you want to wear that mask. So it's important. Infection control, I know we are all tired. This is a time that people need to go out on the floors and say, hey, do your hand washing, and come and be there for the next session where they are talking about cleaning common equipment, a lot of fomite transmission. So think about that. It is so important for leaders in your buildings to actually walk the halls and remind people why it is so important right now, and also tell them that what we have seen is the surges actually happen like waves. Right now, it's a big wave. It will recede. It will go back down. So, it's not a never-ending problem, but frame it as something that we need to just, take care of right this minute. Although I would say infection control is important at all times so that we don't get into trouble with other infections. Testing is an important strategy. Test. Why? Because it is important for you to know A lot of times we're like, oh my goodness, I don't want to have a positive patient. But if you didn't test that patient tomorrow, you're going to have 6 or 10 positive patients because it's so transmissible. So your strategy of testing and early cohorting is extremely beneficial. Next slide, please. All right, so this is a cool slide that I made. This is what is going to tell you about, when you talk to the staff and you talk about, why should I take the vaccine? Here is what we know. If you are up to date vaccinated with your mRNA vaccine, you are 70% protected against symptomatic infection. You're also exempt from twice a week testing that we all have to go through if we are not up to date vaccinated. Number 2, you are 8 out of 10 times, 8.5, almost 9 out of 10 times protected against hospitalization. So, most of the hospitalization that we are seeing still are either people who are immune compromised or people who are unvaccinated or not up to date vaccinated, because the lines and we're going to talk about it in the next slide, but you are also protected against ED visits, having to make those ED visits. And the most important thing, you are really well protected against mechanical ventilation and death. So these are the numbers that you need to tell the staff. 7 out of 10 protection against disease, 9 out of 10 protection against hospitalization, and almost 9.5 out of 10 protection against death and being on ventilator. Very, very profound numbers. Next slide, please. All right, so what do we know? Why am I telling everybody you got to take your booster? Here is why. The top line. So these are the number of cases in nursing home. And this is very important for the administrator in figuring out, how can we make sure that our operations are not getting affected? Because here is what is happening. The solid line is unvaccinated people. So these are the number of cases. Solid line is unvaccinated people. The long dashes are the primary series only, the people who only got their primary series, but they were ready for boosters. And the dots are actually people who also received boosters. In facilities where they had higher number of unvaccinated and primary series only people, look at those lines, how close they are. So, if you are really only received the primary series and you're hoping that it would protect you against symptomatic disease, it's not doing an awesome job of it at all. So you do really need to get that booster to bring that number down. What does it mean for me as a facility medical director or to an administrator? It means less number of cases when that outbreak, if it happens, when that happens. Okay, next slide, please. All right, so what do we know? This is a new study that just came out. And what do we know about the effect of third and fourth dose? I am getting a lot of questions about, well, I got my third dose. Is it really helpful to get the fourth dose? So I'm going to quickly go over just the high level view of what is going on here. This first graph is the A graph. That's the top left, is telling you the overall symptomatic infections. And basically, the green one is people who are vaccinated with one booster, but were ready for the second booster. And the number drops pretty significantly with the second booster. The second graph on the same is the hospitalization. So the effect on hospitalization is even higher. The third one is the hospitalization with severe COVID. And look at the effect. The graphs are kind of, it's really, really beneficial. You're seeing the benefits. And then the COVID deaths is the fourth number. So what the point that I'm making is, if you're resident, it's so important for us to use this as a strategy for decreasing the numbers of patients in COVID outbreaks, decreasing the chance of the patient, even if they get COVID, to having to send them to the ED and potentially dying and having severe COVID illness. Okay, next slide, please. All right, so this is a checklist that I created that I would love for you to, it's something that you can actually print out and say that these are the things that we need to focus on in order to make sure that our census is good and our patients are safe and we are not having, those repeat hospitalizations, and we can manage the patients. So up-to-date vaccination, both of residents and staff, PPE, and test early. I am going to go over how we created this checklist and what is the strategy behind it in the next slide. Next slide, please. Okay, so our goal is a resident. Our goal is to keep the residents safe. And, I have often talked about the wall of protection that we need to create between this community that, may or may not have high vaccination rates, but also between the community and the resident. So essentially, who is standing between that? It's your walls and your staff that is standing between them. So let's talk about that. From a staff perspective, on the left side is the staff. If you increase the staff vaccination, you have healthier staff. That staff is less likely to get COVID and less likely to give it to your resident. Now, for the small chance, if you have a very highly vaccinated staff, for the small chance that they may have that transmission happen, you want to ask your staff to have an N95, a very high grade mask and face shield during the time when it is surging in your community, because this is level 1, bam, bam, 2 levels of protection to the resident from a staff perspective. From family members' perspective, you want to make sure that your family members are educated. You have number one, a visitation policy. Ask them about the vaccine. You don't have to basically say, we are not going to allow you to come into the building if you're not vaccinated. That's something that we cannot do. But take that opportunity to counsel and tell them that, highly vaccinated people around your loved one is going to actually keep your loved one safe, and make sure that you give that mask and enforce that mask right now for your families, which means they cannot jeopardize, while they can do behind closed doors with a patient only, whatever they're doing. Although I would counsel them that during the surge, you should really wear your mask so that, your loved one is safe. What they shouldn't do is jeopardize other people. So while they're in the hallways, they're supposed to be masked with the nose and the chin enforced. So that is important. Allow people who have trouble with doing that, allow them to, an avenue to go outside and have outside visitation if possible. All right, so patients among each other, the other strategy is among each other, again, less risk of getting COVID, less risk of giving it to the other residents, their co-residents, and then try to counsel them on the masking, especially during this surge time. This is a fight. This is a fight that we are in right now. We got to fight. Everyone has to fight together, and they need to feel like they're a part of that fight. So positively couch that response of wearing a mask and making sure that they are keeping their friends safe and themselves safe. Next slide, please. Okay, and finally, we are seeing a lot of patients test positive in our nursing homes. Remember that you have this modality available to you, and I can certainly talk more about it, but I did want to let you know that your number 1, 2, 3, and 4 strategies, once you have that patient positive, all your nursing home residents are at higher risk for deterioration and hospitalization. So they, by definition, will meet the criteria if they have mild to moderate symptoms to get therapeutics, which is medications treatment for COVID. And Paxlovid is available. Make sure that you have the logistics when that patient tests positive on the weekend. You have Paxlovid available and a channel to have that available. It is a little bit of a complicated process because you need to make sure that their liver and their kidney function is stable and they are not having significant drug interactions. So you need to make sure that you are um, involving your clinical pharmacist, consultant pharmacist in this process. Remdesivir is your number two. So the most favorable is Paxlovid. It's an oral medication. Remdesivir is IV, but it is IV with once a day for 3 days. Your other are the monoclonal antibody, and the last one is molnupiravir. So those are the four things. When you have a patient, think which one should be the right therapeutic to give to the patient, and always consider therapeutics so that we can have that decrease in the severity of COVID for the patient. Next slide, please. And always remember, prevention is so much better than cure. So it's the vaccine, 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 and boosters. So thank you so much.
Well, Dr. Garth, thank you so much for your presentation this morning. And just so that everybody knows, in just a few minutes, I'm going to drop the link to the slides in the chat box so that you can grab those. They're posted out on our Alliant website. Some of those slides you might want to use, especially the graphs, for your staff presentations or your staff education. So we want those to be upfront and available for all of you. Again, Dr. Gar, we thank you for being here. We know that you're probably going to have to drop off. So if you have questions for Dr. Gar, please put that in the chat and I will get those to her. At this time, we're going to switch over and start talking about something different than COVID. And we're going to have a presentation this morning on C. diff, or Clostridioides difficile. And I'm going to turn the presentation over to Teresa Fox, and sitting in for Dr. Raven Speltz, and I think Regina Howard may have a part of this. So Teresa, take it away.
Good morning. As she said, I'm Teresa Fox, and I will be presenting for Raven this morning. So bear with me, especially on some pronunciation of drugs. Raven is present on the call. She just can't speak. And so if you have any specific questions, she'll be available to answer those. So today we have listed 7 objectives, and among those we are going to discuss what are the current treatments for CDI, what are the infection prevention and control practices that are necessary, and a little bit about antibiotic stewardship in nursing homes. On this slide, we want to refresh you about a few abbreviations and definitions. We give you the definition for CDI, what is CD, what is PCR? We've heard that term a lot. What is an antigen? And of course, what is a toxin? And I want you to remember that C. diff always produces 2 exotoxins, toxin A and toxin B. You see that in your reports a lot. So Clostridium difficile exists in soil, water, air, human, and animal feces. C. diff spreads through direct contact or through fecal oral contamination routes. The symptoms can range from mild diarrhea to severe inflammation of the colon, resulting in fever, loss of appetite, nausea, and abdominal pain. C. diff causes about 1.5 million infections in the United States annually. Of those, more than 80% of all C. diff deaths occur in people greater than 65 years of age. There are some common risk factors identified. One is recent antibiotics. People that are 7 to 10 times more likely to get C. diff while taking an antibiotic or in the month directly after taking an antibiotic. Of course, age is a risk factor. Whether you have a recent hospitalization or whether you live in a nursing home is an identified risk factor. Of course, if you have a weakened immunity system or, as spoken earlier, a previous infection. Colonization in nursing home ranges from 4 to 20%. Remember, the word is colonization, which is different from an active infection. a person may test positive for C. diff, but not have diarrhea. It is important to remember not to treat your colonized residents, and you should not be testing your colonized residents. A major concern, as we spoke about earlier, is antibiotics, which are given. And you'll see this CDC slide says that 70% of nursing home residents will receive at least one course of a systemic antibiotic in a year. And part of that we have to remember is a large majority of those antibiotics are given to people when they were not needed, like for viral infections instead of a bacterial. It was inappropriately given. Maybe it was the wrong dose, it was the wrong drug altogether, or it was given for the wrong duration. We should always consult the CDC treatment regimens to make sure that the antibiotics that we're giving or that we are giving the correct drug, correct route, and the correct duration. And some of those durations have decreased in the recent years. On this slide, CDC shows that in long-term care, we saw an increase in antibiotics during COVID. It was particularly true for Rocephin and azithromycin. You can see these peaks quite clearly during the pandemic. Azithromycin had a major change, even though there is little evidence to support the use of azithromycin for COVID treatment. The IDSA, which is the Infectious Disease Society of America, does not include either antibiotic in its guidelines for COVID treatment. So now let's talk a little bit about diagnosis of C. diff. Let's begin with what residents are exhibiting signs of C. diff. First and foremost, the resident with at least 3 unformed stools in a 24-hour is a possible candidate. When I talk about unformed stools on the chart, the Bristol chart on the right, that's type number 7, where it says it is a liquid consistency with no solid pieces, meaning it takes the shape of the container that it's in. And when you're thinking about those, should I test or should I not? I would consider having a flow chart or something that describes those particular times it should be done, and do that through nursing standing orders. You should always consider, is this resident on a laxative? Are they on antibiotics? And if they're on an antibiotic, could that antibiotic be discontinued? Are there other possible causes for the antibiotic, for the diarrhea? Such, did they have an enema? We see that quite often. You got to keep those things in mind. And of course, I want you to remember, if you test for CDI and your test result is negative, you should not retest within the next 7 days. On this graph, this is just a kind of a structural for testing. A lot of us are doing stool toxin tests that have a multi-step algorithm. This chart defines that algorithm and whether your positive and negative results, what your implications are, and what should be your treatment actions in each particular case. So now let's get into a little bit of treatment. Let's go to the basics first. Do not use an anti-diarrhea medicine with a person that has C. difficile. That person needs to excrete the toxin from their system, and it's going to be through the diarrhea that is accomplished. Briefly, I want to mention, do not test for cure. And Regina will go through that a little bit better during infection control. You need to say, and look, has this resident had CDI before? And if they had, what was the treatment and what was the results of that treatment? I want to point out that the IDSA in 2017 did no longer include Flagyl as one of their recommended treatments for C. diff. In 2021, in their guidelines, they added Difficid or vancomycin. And if the Difficil is available, I understand it's quite costly, and that would be your first choice for the treatment of the C. diff. The Difficil is recommended because it tends to decrease the reoccurrence of the CDI. So when we talk about the initial treatment, as I said earlier, Difficid is going to be your first line of choice. You're going to give it BID for 10 days. And then your second choice would be your vancomycin. And then, of course, your third and alternate choice is going to be your Flagyl. Flagyl is inferior to your vancomycin treatment because Flagyl tends to have a higher mortality rate than your vancomycin does. And as we spoke of early, reoccurrence. Reoccurrence is a true issue for C. difficile. As you can see from this slide, about 1 in 6 of your patients or residents who get C. diff will get it again in the next 2 to 8 weeks. So we need to be conscious of that and look for that reoccurrence. So for your first occurrence, we've kind of briefly talked about what those should be. Okay, but the next few slides, we're going to describe the current recommended treatments for residents with their first reoccurrence and all their other subsequent occurrences. So the first occurrence you can see. The second and all other occurrences, these are your recommended treatments. You will notice that fecal transplants are one of those, and it is used for severe cases of reoccurrence, and it has shown really good results. However, you have to remember the resident would have to go to the hospital for a colonoscopy and to be performed, and the insertion of the donor healthy feces into the patient. Now, the monoclonal antibody treatment targets toxin B. It lasts for about 3 months, and it is recommended to decrease the risk of reoccurrence, but it's always used in combination to other standard treatments. This is another one that has to do with hypertension or shock. And then our old faithful vancomycin. It is commercially available either in a capsule or oral solution. It can be administered orally or rectally, but it does have side effects. Signs of low potassium, such as muscle pain, you should be watching for. It does cause gas, abdominal pain, nausea, and diarrhea, and often a headache. But remember, vancomycin is cheap. And then we talked about earlier about the Difficid. We recommend, I want to close this section by recommending that you share this information with your pharmacist. Next slide. I am so sorry. Okay. Now I'm going to turn it over to Regina.
Thank you, Teresa. Good morning, everyone. My name is Regina Howard, and I'm one of the infection preventionists with DPH. And I'm going to talk to you relative to infection control and prevention as it relates to C. diff. Next slide, please. Teresa talked about colonization and infection, and she told you what the differences are between colonization and infection. And with colonization, colonized residents do not have a disease caused by C. diff and often exhibit no clinical symptoms. Colonized residents may also test positive for C. diff. And it's very important that you have a conversation with your lab to determine how they test for C. diff. C. diff requires a multi-test situation in the lab. So that's why it's very important, because they can test positive for colonization, but what you want to know specifically is if that toxin is being produced. And that's going to make all the difference. That's why it's important for you to have multi-testing in the labs. So someone should definitely be talking with the lab people to determine whether they're doing that multi-step testing for C. diff. Next slide, please. C. diff prevention efforts include conducting surveillance during calculation within the facility itself. It's very important that you track your C. diff. I also like to mention the fact that part of the NHSN patient safety is testing and reporting C. diff through NHSN. Next slide, please. Pillars of C. diff prevention and control. Hand washing. Cannot stress hand washing enough. Very important. When you perform hand washing, to utilize soap and water. Why? Because the alcohol-based hand rub does not kill the spores. So that's why it's very important to utilize soap and water in those situations. These residents are also placed on contact enteric precautions. Also, I cannot stress the significance of environmental cleaning and disinfection and antimicrobial stewardship. Next slide, please. Again, hand hygiene, cannot stress how important that is with soap and water. So you should be performing hand hygiene before contact with the resident, after removing gloves, after contact with the environment. Also, for enhanced measures, do not utilize, again, alcohol-based hand rubs. Use soap and water in this situation for C. diff. And it's very important that staff entering and exiting that room, that audits are performed to determine that everyone is doing what they should be doing in this particular situation. Next slide, please. This is a pretty wordy slide. Standard and enteric contact precautions. That's the sign that you should be utilizing for C. diff. You'll see on the right. It's important that you create nurse-driven protocols to facilitate and rapidly identify isolation of residents with suspected or confirmed CDI. So it's important to establish a flow chart so that perhaps this may occur at a time when the powers that be may be on vacation. So this way, the staff who's in your facility will know immediately through this flow chart, what should they be doing should a resident develop diarrhea. Next slide, please. Environmental cleaning and disinfection, again, very important. Create policies and procedure to ensure a systematic approach. So increase the frequency of cleaning and disinfecting, particularly for high-touch surfaces. Bed rails, overbed tables, call lights, very important in this situation. Auditing, again, very important. Some facilities, what they do is they utilize the fluorescent markings to audit as to whether or not housekeeping has cleaned this room appropriately after discharge. So what they do is they have a fluorescent marking where they make marks throughout various areas of the room to be cleaned. And once the room is cleaned by housekeeping, they come back with the fluorescent light and look at those areas that they marked off to determine if proper cleaning was performed or not. So it's very important because you don't want to transmit C. diff to the incoming resident for that particular room. So this is a very important step, environmental cleaning and disinfecting. And not only that, I want to say, applaud your staff when they do a good job. Establish some type of recognition to let them know that they are appreciated and that they've done a good job. So that's very important, because I think many times the housekeepers are not recognized for what they do. And what they do is extremely important to prevent transmission of organisms. Invite them into maybe one or two into your meetings, and find out if they have questions or concerns relative to the environmental cleaning and disinfection. So next slide, please. Before cleaning, again, perform hand hygiene. There are certain EPA approved disinfectants that you should utilize for cleaning the C. diff room. And there's a list of those disinfectants that's in the slide. I believe it was in the previous slide. So again, cleaning, start from one point in the room and move in a clockwise or counterclockwise direction to ensure that no items in the room is missed. And you clean from the least soiled to the most soiled, ending around the patient and the patient's bed, a resident's bed. Again, utilize the environmental EPA approved registered disinfectants for cleaning C. diff rooms. Your regular quats are not effective against the spores in C. diff. So that's why it's very important that you use an EPA registered disinfectant for your cleaning and disinfection. Again, your privacy curtains, when a resident is discharged, those curtains should be replaced. And if they become soiled during use, then again, they should be replaced. Next slide, please. Okay, interfacility infection control transfer form. It's very important when these residents are transferred to another facility that you have a conversation with that facility. Let them know that this resident has or has C. diff. With C. diff, you can be colonized for long periods of time. You may no longer have the diarrhea, but you remain colonized with that organism. And again, as Teresa said, when residents are having diarrhea, sometimes that diarrhea may not be because they're positive for C. diff. It may be because something else is going on. So if that resident has a history of C. diff, even though the diarrhea may not be caused by C. diff, that resident will still require isolation because, again, they're colonized, which will be reflective in that diarrhea. So again, remember your transfer form when you're transferring these residents. Next slide, please. I think that's the last slide regarding that. Okay. Thank you.
I'm going to talk now, and Maya, I'll try to do better this time about telling you to advance slides. Sorry. Okay, so as you can see on the pillars for antibiotic stewardship, the final column was antibiotic stewardship. You know, antibiotic stewardship is very important, not only for C. diff, but multi-drug resistant organisms because of the avoidance of creating them. So anytime that you cause even one dose of amoxicillin from a dentist can create C. diff. So you must consider it high risk. So the other drugs to avoid are antibiotics are your fluoroquinolones, which is your Levaquins. Those are given quite freely because they're cheap and they're easy to give. Another risk drug for antibiotics is going to C. diff is going to be your carbapenems. And of course, your last ones are your third and fourth generation cephalosporins. You should always use the shortest duration for the therapy. you should always have a documented indication for that antibiotic. You should try to develop facility-specific empiric antibiotic guidelines. And a tool that's going to be quite helpful in doing that is having a facility antibiogram. And I know most of you don't know what an antibiogram is. An antibiogram is when you look at the cultures that were collected in your facility over, most of the time in long-term care, it's for 2 years because you don't do enough to do it on a yearly basis. And what they take the sensitivities from the organisms by specimen type and tell you what percentage was acceptable to that drug or was resistant to that drug. Okay, so if I didn't do enough cultures, what I would ask you to do is contact whoever does your cultures and ask them for a facility-specific antibiogram. And if they tell you that they do not have that, ask them for a 2-year. And if they still say you do not have any information, better than nothing is to call your acute care facility that most of your residents are admitted to, ask for the infection preventionist, and ask them for a copy of their outpatient antibiogram, which should be very close to what is the susceptible drugs in your area. This will help you set up your empiric guidelines. Example, in the community that I live in, for UTIs, if they came to the hospital, it was going to be failed outpatient treatment. And when we would look at those drugs that were given outpatient, most of the time, I would say probably 85 to 90%, they were given Levaquin. Okay? When we looked at our outpatient antibiogram in our community, 85% of all E. coli, which is going to be your most common organism, was resistant to Levaquin. So you need to know, don't be doing empiric treatment antibiotics to organisms that your general biome is already resistant to. So that's very important. Take those people and see if you can get a copy of those antibiograms. Another good resource for you is that CDC has set aside in November what's called the U.S. Antibiotic Awareness Week, and that was the next slide. But these materials are available all year long, and they have really good posters and suggestions on how to educate and for awareness of antibiotics. Next slide. So CDC has developed what they call the 7 elements of antibiotic stewardship in long-term care. They are specific for long-term care, and I gave you the website at the bottom if these are available. But the 7 elements are leadership, commitment, accountability, drug expertise, action, tracking, reporting, and education. And I am just going to go through these very quickly. Next slide. When you talk about leadership commitment, you need to have, it's very important to have that written statement of support and make sure that the people that are leading the charge in antibiotic stewardship is directly written into their job descriptions. And of course, you must have leadership stewardship policies. Next slide. When you talk about accountability, that's when the best practices are set up by your leadership. And there should be a committee. It usually involves your medical director, your DON, your consulting pharmacist, your infection preventionist, your laboratory, and sometimes your state and local health department. Next slide. Drug expertise. As a infection preventionist, and I do not, in the long-term care, I do not think we utilize our consulting pharmacies as much as we should. You can get expertise from your local hospital, like I talked about the antibiogram from them. And of course, you need to have access to an infectious disease provider. Next slide. So what are your actions going to be? You know, you're going to develop and promote policies that enhance your use of antibiotics. You're going to target certain interventions, that you're going to have an antibiotic timeout. And a lot of people will use that. You know, it usually takes 2 to 3 days to get a culture and sensitivity back. So they do like a 72-hour timeout. Initial empiric drugs are ordered for that initial 72 hours. It has an automatic stop on it. It forces you to look at the sensitivity for that specific organism. And then if it's negative, you do not restart an antibiotic. And then if it does need an antibiotic, you restrict more, go to a less broad spectrum antibiotics that is specific for that organism. Make sure that it's appropriate, and utmost review all your cultures timely. Don't have them sitting in your office for a week and then look to see if the drugs were appropriate. Next slide. Tracking, of course, we've talked about tracking before. Be sure that you track all your interventions, measure your antibiotic use, track certain outcomes like CDI, UTI, multi-drug resistant organisms, and of course NHSN has a program or a module that will track these for you. So if you want more information about that, you can either contact Alliant or the Georgia Department of Public Health. Next slide. Reporting, be sure that that you're reporting to your antibiotic stewardship, that your medical director, and I would make sure that all of my medical providers are getting that information, especially my antibiogram and what their specific provider information. Next slide. For elements education, you should include all your employees. It's really hard if you're trying to cut down, say, giving an antibiotic for upper respiratory infection, and your resident says to your CNA, I've been coughing for 3 days. And she said, well, I think you need an antibiotic for that, right? So let's make sure that we're educating all your staff when it is appropriate to give an antibiotic. The antibiotics don't treat respiratory infections. And when 85% of all upper respiratory infections are viral, they're not bacterial, we need to really be conscious about giving those. And I know you get a lot of pushback from families and residents about that they need an antibiotic. Take the time to educate them the risk versus the benefits of having an antibiotic for only when it's indicated. Next slide. Of course, there's continuing education on antibiotic stewardship. We give you the website, and that's the CDC training on antibiotics. Slide. This is a flyer that's quite helpful, the 4 moments of antibiotic decision making that you will find. It helps to educate your residents and your families about the appropriate use of antibiotics. Next slide. And then we're going to, there is 2 veins of thought on probiotics. Some say there's insufficient evidence to recommend, and others say prevention of CDI when taking antibiotics. So there's more to come on those particular probiotic use. Next slide. PPIs, try to discontinue your PPIs if there's not a defined, clear indication on why that PPI is being given. Next slide. And this is just our contact information. And I will turn it back over to Mel now.
All right. Well, thank you, Teresa, and everyone. Again, if you have any questions or thoughts, please drop them in the chat. I have again dropped the link for today's slides into the chat box so that you can grab those. Teresa's given you several good opportunities to go out and pull the information from AHRQ, as well as CDC. for things that you can print off or that you can use for some of your staff education. And additionally, Dr. Gar had some good graphs in her presentation today that you might want to use for staff education to reiterate the importance of the boosters, where we are, where we were, and now where we are today, and how the changes are affecting not only our residents, but your staff as well. So again, if you have any thoughts or comments, I think we've had a couple of questions that I will send on to Dr. Gar, but drop those into the chat or the Q&A box. And so for the purpose of time, because we're right up on the hour now, we're going to move on. So next slide, Maya. And we'll have a poll dropping in just a moment. I just about forgot that. Please answer this and give us your thoughts. Again, for next month on August the 19th, go ahead and put that on hold on your calendars. We're going to be talking about cleaning and disinfecting of equipment. I think you got just a little bit of a thought process today as we talked about C. diff, but Teresa, Regina, and team are going to go more in detail with everything, not just C. diff. Next month on August the 19th at 11 a.m. and you will be getting an invitation for that closer to the time, usually the week before. Next slide. We want to thank the Georgia Department of Public Health, Teresa and Regina, great job today. And also for Dr. Ravensbelts and Renee Miller for their input on the slides that you received and the presentation that you were given today, as well as the University of Georgia, as we all work together to bring you these strike team information. Slide. Last but not least, as always, we want to ask you to join us on Alliant Health Solution social media platforms. So a lot of the information that you have heard today, you might see in some snippets out on our platforms. And also a lot of the other materials that we are producing, you will find out on our social media, to include Facebook, Twitter, LinkedIn, and YouTube. Again, I thank you for staying with us all the way through this whole presentation. We hope that it has been beneficial and that you have several resources now to take back to your nursing home and to your staff and for your residents as we all try to make healthcare better for everyone in the state of Georgia. So thanks, everyone, and we'll see you next month.